My name is Dr. Renaldo Pavrey. I am a senior consultant in emergency medicine at the Nanavati Max Hospital in Mumbai. I also am the chief of the accident and emergency department here, where we have a very capable and qualified team of specialists who work with me in managing cases that require emergent and acute care. A brief introduction to what it is that we do and who we are. Emergency medicine is of late coming up as a specialty. In India, there was no signs of emergency medicine prior to maybe the early 2000s. But now, a lot of developments have taken all over the country, and Bombay is soon catching up. And at Nanavati Max, we hope to transform this emergency department into a center of excellence. What that means to you and for you is that we assure the best care in terms of prompt assessment and timely critical intervention. The reason that we are focusing on qualified and trained individuals is that we don't miss out on the subtle things that very often are taken for granted, which can compromise on the quality of care for you and your loved one. Allow me to run you briefly through the processes if you ever happen to set foot into the emergency department at Nanavati Max. Once you enter the department, every patient is put through triage. We have a designated area for all our triaging. Triaging is essentially sorting of patients so that the most critical individuals are cared for in the most prompt fashion. All your patients are taken care of. But the emphasis of our triaging is that we are quickly able to sort through which patients require immediate attention. A section of our triaging comprises of beds which are allocated as per the requirement of the patient. We have 8 beds in our emergency department that are structured for this. We follow a triaging system which is color coded, and it is based as per the severity of the individual. 2 beds which are kept in what we call the acute care area is right in front in the main area of the department, which is reserved for the most acutely and critically ill individuals. We have another 5 beds which are in an observation area for lower acuity individuals. We also have a separate designated resuscitation bay which is kept in an individual room, ensuring privacy during cardiopulmonary resuscitation as well as secluded from other individuals. This room is utilized for only the sickest individuals or individuals who are brought in cardiac arrest. The emergency department at Nanavati Max sees and deals with a lot of geriatric cases, the elderly. And in our experience, the elderly are the most frail, the most fragile, and require not only prompt attention, but a very delicate and soft skill. In our department, the doctors and the nurses are not only capable and skilled in managing the clinical problems of elderly patients, but they are also well versed and trained in the soft skill aspect of dealing with these frail adults as well as their family members. In our department, the commonest cases that we see involving the elderly are those in which they are brought in sick and septic. When I say septic, I mean an infection which no longer is localized to a system but has spread through the bloodstream. We see a lot of elderly people who are brought in on day 4 or 5 of their illness in sepsis. The reason I mention this is to connect to another topic which I wanted to highlight to the audience, and that is about sepsis. In my experience here, we see a lot of infections which have spread through the bloodstream but are very often missed and just mistaken as benign illnesses. Why I am saying this is because it is our duty as emergency physicians to promptly identify septic individuals, especially the elderly. The elderly have a very poor reserve and infections escalate rapidly and make them deteriorate at a much faster rate. We make it our responsibility and our duty to quickly capture these individuals who are septic and do what is required to minimize their morbidity and mortality during their stay in the hospital. A sepsis protocol is applied at large to most of these individuals. We make it a point to administer broad spectrum antibiotics within 60 minutes of these individuals arriving into the emergency department. We believe that this can significantly reduce their stay in the hospital and also improve outcomes. The geriatric population require prompt attention. When we talk about the elderly, we also see a lot of trauma related to the geriatric population. This is commonly seen in terms of a fall at home, resulting in either head trauma, spine trauma, or hip injuries. Hip injuries being extremely common, we do encounter a lot of these in our department. The emergency department has a very close rapport with the departments of orthopedic surgery as well as the departments of spine surgery. And we make it a point that these elderly frail people with falls are immediately stabilized so that no further harm can come. The relevant radio imaging is done in a secure fashion, and then the respective teams of orthopedics or spine surgery are promptly alerted. In our department, we believe in an interdisciplinary approach, which means that multiple specialties will deal with a patient simultaneously. The emergency department at Nanavati Max handles all kinds of trauma. We see multiple victims of trauma following motor vehicular accidents, and we are well versed and experienced as well as capable in handling them. This is in part also related to a strong EMS system that we have. Our department has an ACLS equipped ambulance with a doctor and with a trained nurse and with all the required equipments, so that these accident victims have the option of being shuttled to our hospital in our own ambulance. Our specialists are well trained in handling all kinds of polytraumatized victims as well as minor injuries. These are all dealt with in the emergency department itself. For complex injuries, we have a very close understanding and rapport with plastic surgery, maxillofacial surgery, neurosurgery, orthopedics, and general surgery. Let's talk a little bit now about acute strokes and heart attacks. These two acute medical emergencies are now become very rampant, and they are extremely time dependent. Because they are time dependent, I believe it is imperative that there exists a proper structure and protocol in every emergency department to streamline the processes when such patients arrive. For managing acute stroke cases, our department and the hospital have created their own system in which the moment the patient arrives at the doorstep, there is prompt evaluation in under 5 minutes, and then this patient is quickly mobilized for an MR angio with immediate reference to a specialist team of neurologists. In order to prevent any lapse in time, the hospital has devised a code for such an event known as Code White. The moment Code White is alerted, all the passages from the time the patient reaches the emergency department till the time the patient is admitted in the ICU, all those passages clear up. What is brilliant about such a code is that on sounding of this code, there are no access blocks at any level to the patient. When I say access blocks, it can be right from emergency to billing, or from billing to radiology, or from radiology to the ICU, which involves the admission process. Code White ensures that there is no time delay in any of these processes, and the patient is attended to promptly, assessed promptly, undergoes a radio imaging safely with doctors present, and then a plan is made as soon as possible. A very similar analogy can be given to heart attacks and the way we manage heart attacks in Nanavati Max emergency. The medical term for it is an acute myocardial infarction, and we see a lot of these cases in our department. Using the example for code white, its sister here is code green. Whenever we have a case of an acute myocardial infarction, the moment the decision is made to mobilize this individual for a primary angioplasty, code green is alerted. It functions in the same way as code white, in which case there are no access blocks and there will be no time delay, be it in terms of an economical reason or in terms of structural problems. For example, is the cath lab available or not? The moment code green is sounded, all the relevant stakeholders are alerted and there is no interruption in treating the patient. On a side note, both the acute strokes and acute myocardial infarctions are primarily handled by the emergency physician. If your patients are brought in obtunded or critically ill, the primary stabilization happens in the emergency department by the emergency physicians. This assures that there is no time lost, whether the patient has to go for an MR or whether the patient has to go to the cath lab. Neurology and cardiology work in an interdisciplinary way with the emergency department, and that ensures the best possible chance of a good successful result. The important thing that I would like to highlight here is cardiopulmonary resuscitation. CPR as we know it, basic life support, advanced cardiac life support. These are also in tandem attached to advanced trauma life support and pediatric advanced life support. As emergency physicians, our primary job and our primary training are as resuscitationists. When I say resuscitation, I mean those of critically ill individuals who probably require the most urgent care within 10 minutes of arriving into the emergency department. By having quality, trained, qualified people, we ensure that the individuals who need resuscitation within the first 10 minutes of coming to the department get what is needed. There is no delay waiting for other specialties to come and intervene. Cardiopulmonary resuscitation is a very important part of our role and we take it extremely seriously. We also partake in training, be it for medicos or also for lay people. For lay people, it's part of an outreach program where we also go to the public at large and treat and teach them basic life support. This is very, very important to understand basic life support as the public, to seek medical care as soon as possible after initiating basic life support, and then transporting your patient to our department so that this resuscitation effort can continue.